Barakat, can we start? Okay, I think we have lost Barakat. Dr. Rajveer, welcome.
Well,
introduce yourself to our audience first, then your presentations, then if we have any questions from the participants, I will try to bring those up. And of course, I have also my own questions. We want to learn from your experience in the US, and specifically from the urology side, what was happening, how are you dealing, and what the future may hold. What do you think will happen in the next few years?
Well, to begin with, thank you, Dr. Wanda Wasson, for having me. It's nice to see your face after a couple of years. You look healthy and younger than when I last saw you, so clearly time has been treating you very well. I want to just start by saying, I'm a urologist. I think the audience are all urologists, and I'm not an infectious diseases doctor.
Okay.
So I don't know all of the details of the viral particles, how it replicates, which receptor, these kind of things. But I thought this would just be a general sort of talk about what kinds of things we've experienced here in New York, and what are some of the lessons as urologists that I take away. I thought I'd break the talk down into two parts. The first part of the talk will be on just general background about COVID and some of the data and what kind of treatment options are available. And the second part of the talk will be on what I think lessons we can learn based on both New York's experience as well as a couple other countries' experiences about what's happened to COVID. So just to begin with, we'll start with the background. I think sort of everyone who's listening to this talk probably already knows this, but COVID is basically a novel disease in the sense that it's a new disease, but it's related to the SARS coronavirus family. And so these are, the SARS first came out in 2013. And so a lot of the treatment options that we've been looking at has been based on what might have worked in SARS, the SARS epidemic back from then. And so, the kinds of medicines that scientists have been trying, as I'll show in a second, work for SARS, and we're hoping that they may work for COVID as well. The first set of cases were likely transmitted from consumption of bats in Wuhan, China, at live animal markets. This was in December of 2019. But there's likely an intermediate animal vector that we don't know about yet. So it is known to exist, for example, in dogs. And there are some cases in China in which patients were not clearly exposed to having consumed bats, or to other patients who had SARS. So they think that there may have been a secondary animal vector that carried the virus and caused the infection. The first actual series of reports came out on December 31st in 2019 in China, and that's why it's called COVID-19. So there's a lot of different names for COVID, including SARS-CoV-2, because it's a second version of SARS essentially, as well as COVID-19. For the purpose of this talk, I'll just refer to it as COVID, with the idea that we all know sort of what I'm talking about. And one of the keys to this, to understanding how this gets transmitted, and the epidemiology of this is R0 number. So R0 is the number of patients that each person who's infected subsequently infects. It was initially estimated that the R0 is 2.4, 2.5, at least in America when the virus first came here in New York City, which means that every person who has it infects 2.5 other people. So you get exponential growth of this virus as a consequence of that. But as we do these lockdown measures, as people are avoiding are doing social distancing, the R0 number declines to less than 1 and gets down to probably about 0.5, 0.6 in that range. And just like you have exponential explosion of the virus in terms of its growth, you also have exponential decline in the number of patients because every person is only infecting half the number of people. So the virus can come very quickly and also go away very, very quickly. And this number is sort of key when we talk about how do we control the disease. Now, the way it gets transmitted is through 3 different ways. At least this is the way it looks right now. It's clear that respiratory transmission is probably the main mode of transmission. This is if you cough, if you sneeze. These viral particles are about 1 to 10 micrometers in a second. There's also contact transmission, which is, if you touch something that has COVID on it, then you touch your mouth or some kind of mucous membrane, subsequently you can get the virus, as well as aerosol, which is particles that are less than 1 micrometer and may occur just from regular breathing. Now we'll talk about each of these in turn. So, with respiratory transmission, most common things are sneezing and coughing, and these respiratory droplets that get transmitted in the air are felt to exist for at least 6 feet, but I think increasing data shows that the particles exist for a pretty long time in the air and may expand more than 6 feet. And so this is something that's a little concerning, the fact that we have to worry about how far apart we are. We've always used a 6 feet rule between, like if you go to the grocery store in New York now, they're asking everyone to stay at least 6 feet apart, but the numbers may actually be larger than this. Now, in terms of contact transmission, there's a very good paper that came out in the New England Journal of Medicine, which has been publishing essentially every week multiple articles on COVID, and has been one of the main resources for me to understand transmission of COVID. And this article looked at or compared COVID-19 to the SARS coronavirus to look at how long particles stayed on different surfaces over time. So the first sort of column, which is under the aerosol, the first column on the left side are all the aerosols. That is, if someone breathes, how long it stays in the air. The second is copper. The third is cardboard. Fourth is stainless steel, and the fifth is plastic. And if you focus sort of on the middle set of graphs, the red is the coronavirus or the COVID-19, and the blue is essentially the original SARS COVID-1 from 2013. So there, or 2013. There isn't a huge difference in these numbers, but if you look at the red, you can see that copper coronavirus is probably the least stable, and it exists for really less than about 10 or 15 hours. What's a little concerning, though, is the third column rather, with cardboard. You can see that coronavirus exists for almost a day on cardboard, and at least the particles. So if you get packages delivered to you, or if you have cardboard boxes at the hospital that someone's coughed on, these viral particles could potentially exist for some time on it. What we do here is when I get packages or if I get a new cardboard box from someone, I usually leave it aside for at least 24 hours or at the minimum wash my hands after getting these packages. Stainless steel is about 3 to 4 days and plastic is about 3 to 4 days as well. So, in a place like New York City, where a lot of people live in high rises, and there's a lot of stainless steel for elevator buttons, or if there's door handles, this is something that could be a significant source of spread. And I'm sure in Addis, where there are a lot of high rises as well, it's something you have to be concerned about. So, always wear gloves, obviously, for this to prevent this kind of surface contact. Now, aerosol transmission, these are viral particles that are less than 1 micrometer, are probably the most concerning for doctors and those involved in surgery. And then the major concern is that there are a lot of procedures that we do, particularly anesthesiologists and surgeons, that generate these aerosol particles. So, intubation, bronchoscopy, open suctioning, even using the face mask rebreather for patients who need oxygen therapy or nebulizer treatments. These are all generating these small particles that are floating in the air. The concerning thing is that there's some data that even talking to a person, let's say you go to the grocery store, that kind of talking may actually be one form of aerosol transmission. The fortunate thing is that most of the data shows that the aerosol transmission is less than 1 foot. So unlike the respiratory particles from coughing and sneezing, which are about 6 feet, this is only 1 foot. But the problem here is that essentially anyone can get affected. Anytime you go to the store, or anyone who's talking to you right up close could potentially be transmitting these particles. But as doctors, we worry about it particularly because these particles are going to be in the air during surgery, after intubation, or after any kind of procedure where we're generating kind of these particles coming up in the air. There's been some evidence that suggests, for example, use of the bovie in patients who have COVID may cause these particles to also get in the air and could be a source of spread. And this is one of the reasons I think why healthcare providers and doctors have had a particularly high risk of COVID over the course of this epidemic. You know, it's been estimated that almost 15% of people who have COVID are healthcare providers, or symptomatic COVID have healthcare providers. And the other thing that's concerning about this is there's some data that shows that the viral load of the particles may play a role in how sick you get from the disease. So if you just get a small viral load at the time of exposure, you may recover much faster and you actually get the antibodies that prevent you from getting sick. But doctors, when they're doing intubations, like anesthesiologists, or when we're doing procedures, there may be very, very high viral loads that are in the air as a consequence. And this might be one reason why doctors are getting, on a proportional level, getting much sicker than the average person who gets exposed to COVID. So we have to really, really be careful about this. So the other thing that is I find really concerning is the question of when is the virus transmissible. There's increasing data, and I think this is pretty clearly established now, that the virus can be transmitted in pre-symptomatic patients or asymptomatic patients. And unlike the SARS epidemic in 2013, in which the viral particle basically replicated in the lower urinary tract, the SARS-CoV-2 or COVID-19 replicates in the upper respiratory tract and sheds from the upper respiratory tract. It can do this even whether or not there's any infection of the lower respiratory tract. So it can start shedding in the upper respiratory tract, go down to the lower respiratory tract, and then they'll stay in the upper respiratory tract while the patient has symptoms. But the concern is that while it's replicating in the upper respiratory tract when patients are asymptomatic, they're basically secreting these viral particles in the air and potentially exposing everyone else to COVID. And so there's a huge number of asymptomatic transmission that's occurring. And this is what's really difficult to control, I think. Now, clearly, when you have symptoms and you're coughing and sneezing, and as I mentioned earlier, you're potentially transmitting this virus. And after symptoms, so you've had the COVID, now when can you go back? What we've been using at Mount Sinai is either 72 hours after the symptoms resolve or 7 days after the onset of symptoms, whichever is more, is when you can sort of go back to work. You still use the personal protective equipment and masks, but at this point, after this point, the feeling is that you're probably less able to cause transmission to others. Now, in terms of diagnosis, probably the mainstay has been the nasopharyngeal swab. Unfortunately, with the nasopharyngeal swab, you have to go all the way to the posterior aspect of the nasopharynx, which is about 7 meters away from the tip of the nose in most patients. So it's a very uncomfortable test. And typically, not typically, but oftentimes the swab doesn't go deep enough. So there's a 15% false negative rate with the nasopharyngeal swab. As a consequence, this becomes tough because you're not even sure if you're negative, whether you actually are truly negative or not. And I've had a couple of friends here in New York who had severe symptoms and whose family were detected to be positive, who tested multiple times with negative nasopharyngeal swabs before they finally were positive. The other concern for healthcare providers is when you're putting the swab into your nose, the patient has a reaction to cough and to basically spew these viral particles at your face. So this is when you really have to be careful about personal protective equipment as you're doing this testing. As an alternative, though, there's been a new test that's been approved by the FDA to look at saliva. And this will probably have a much lower false negative rate because of these issues with the nasopharyngeal swab. It's not yet fully available or widely available rather in the United States, but I think in the future over the next few weeks, it'll probably become much more widely available. And increasingly, it looks like there might be some tests available even at home. So you can see if while you're at home, whether you could be infected or not. So these are sort of the way we're going to make testing a much easier process so patients don't necessarily have to go into the hospital and expose providers and expose other people on their way to the hospital. Now, for patients who've already had the disease or may have had the disease in the past, serum antibody tests are really one of the keys. The antibodies are believed to peak at about 21 days after the infection. So this is when we think that the test will probably be the most accurate. And it's a useful test because it tells you potentially whether you've been exposed or not, whether you're symptomatic, even despite being asymptomatic. But also, there's a lot of feeling that if you have the antibodies, you won't get it again. There isn't great data on this, on resistance. But I think most infectious diseases doctors and experts in the field, including Anthony Fauci, feel like if you have these antibodies, the likelihood of getting COVID again is quite low, which makes it easier if you're a healthcare provider has positive antibodies in terms of going back into the hospital. You still have to use personal protective equipment, but I think it's a little bit reassuring if you have these antibodies. Now, what's interesting, I thought, with COVID is that there's a lot of unusual presenting symptoms. So one of the things that patients sometimes present with is anosmia, or lack of smell, and diminished taste. So their first symptom could be not having any kind of smell for the foods that they normally like to smell. And we've seen this a few times, or I've seen it a few times, even among friends, that they first present with these symptoms and then they later are found to, with a nasopharyngeal swab, to be positive. Older patients can sometimes present with mental confusion. Dermatologists have diagnosed these COVID toe, where they see erythema and tenderness along the toes, and this will be potentially one of the first signs and symptoms of COVID, interestingly enough. We don't know what's causing this, but clearly, if you see this, you have to be careful about it. Now, for patients who have COVID, there's clearly sort of risk categories. Some patients are going to do fine. In fact, the vast majority of patients will do fine and never be admitted to the hospital. And in fact, the majority of patients will never even be symptomatic. But it's clear that there's some conditions, particularly obesity, diabetes, and anything that might immunocompromise patients, as well as elderly age, that increases the risk of having a more severe form of COVID. It's been estimated that up to 20% of patients who are older than 80 years old may die of COVID, whereas if you're less than 30 years old, the chances are almost 1% or less. So it's significant differences in outcomes based on these kind of risk factors. Now, asthma has been included in this disease, but in this list, but I think there's some data that just came out recently which suggests that asthma may not be, if it's mild asthma, it may not be a significant risk factor for developing more severe disease. Now, there has been some concern because of the mechanism of COVID, whether hypertensive medications may increase the risk, or having hypertension may increase the risk of COVID. And there's fairly good data that shows that neither ACE inhibitors, the angiotensin receptor blockers, beta blockers, calcium channel blockers, or thiazides increase the risk of having more severe disease in COVID. So for patients, you can continue to tell them to continue to taking these medications. Interestingly, there's some data that suggests that BCG, which is used in a lot of countries that have tuberculosis as a vaccine, may be protective for COVID. The data is really circumstantial and is not that great, but they have noticed that there's been a decreased incidence of COVID in countries like India, which has used BCG as a means of protection against TB. It's not clear, obviously, as urologists, we use BCG in a different context. It's not clear if that makes any difference, but the idea is that it may stimulate your immune system in a way that prevents you from getting COVID. The data isn't that great on it, but for whatever reason, circumstantially, countries that have had a lot of BCG vaccination also have a lower incidence of COVID. Now, this is the thing that I'm finding increasingly interesting. What we're learning is that COVID, the idea has been that it's a respiratory illness, goes from the upper respiratory tract down to the lower respiratory tract and causes death because of problems with breathing and ARDS. But we're increasingly finding that COVID is actually a systemic disease that's not isolated to the respiratory tract. In one study that came out of Mount Sinai, they found 5 cases of large vessel strokes in young patients less than 50 years old. So it's not a lot of patients, but these patients had significant medical, were basically healthy people who came in who developed strokes. Now, by way of comparison, the authors reported that they had less than 1 or 2 cases over the course of the year in this kind of population. So this is, and this happened over 2 weeks. So clearly there may be some kind of coagulopathy that correlates with COVID. And at Mount Sinai now, anyone who presents with COVID, who's admitted to the hospital, is also placed on anticoagulation as a way of preventing some of these secondary problems that might occur with COVID. Some patients have presented with rhabdomyolysis as an early symptom as well. GI symptoms such as diarrhea are very common. So it's not clear, again, it's clear that the COVID is affecting all these different organ systems. And these COVID patients, particularly sick patients, have a much higher risk of renal failure that's independent from their respiratory status. So this COVID seems to be affecting kidneys in some way as well. So clearly this is not just a respiratory illness, and this is something that's systemically affecting patients in a way that we don't quite understand yet. Now, I had a chance in preparing for this talk to look at different options for treatment. I think clearly, the number one best thing is to prevent yourself from getting COVID in the first place. So this is me at the office performing cystoscopies. So even though basically cystoscopies is probably a pretty low risk procedure, underneath my regular mask, you can sort of see it peeking through is an N95 mask, which filters out 95% of particulate matter. I also have the regular mask over that, so that way I don't touch the outside of the N95 mask. And then we have a face shield over that in case there's any splash. And then I wear a gown for everything. Whereas before, when I did a cystoscopy, I just put on gloves. Now I've sort of put on all of this equipment for a simple cystoscopy. And if you're doing surgical procedures at the hospital, we also obviously, or any kind of, if you're in the hospital, we always wear something to cover our hair as well. For healthcare providers, as I mentioned earlier, because of the aerosolized particles, we're at significantly higher risk of getting these infections. And obviously, in terms of prevention, this is just for healthcare providers, but for a larger population, there's things such as social isolation, lockdown, going out in public, wearing a mask for the general population. And the reason to do that is not because you might get infected, is to prevent yourself from infecting others by wearing a simple mask. But for healthcare providers, I think we have to be particularly cautious. So one of the things that has come out lately, and actually Mount Sinai was one of the first hospitals in the country to do this, is to use plasma therapy potentially in sick patients with the idea that patients who recovered from COVID have antibodies to COVID. And if you inject that plasma with the antibodies in place, then they may have a they may be able to recover, basically. Unfortunately, this plasma therapy data is not that strong. It's all based on a total of 19 patients so far. And this was not randomized controlled trials. These are patients who are already extremely sick, who received plasma therapy from patients who had already recovered from the COVID, and they found a 100% cure rate. But based on this preliminary data, there's been a study that's been sort of coordinated by the Mayo Clinic, including Mount Sinai, including a lot of different hospitals in New York, looking at plasma therapy. So Sinai, as of last week, had 200 patients who had already received plasma therapy. And this will hopefully, preliminary data on treatment of this will come out from this multi-institutional study over the course of the next few weeks. Now, it's typically been used in really severe disease in patients who have been sick and are essentially are dying or are extremely sick. but it may be most effective earlier in the process. So one possibility could be in a role of pre-exposure prophylaxis. So these are patients who have high exposures to COVID, such as healthcare providers. So an idea has been maybe we should be giving them antibodies, plasma antibodies every week or two to sort of strengthen their immune system to prevent them from getting COVID. Also, if you've been exposed to COVID but are not yet symptomatic or are asymptomatic, then the idea that the plasma therapy may prevent you from getting a more severe form of the disease. And in patients who present to the hospital who are not yet intubated, there may be some benefit. And in fact, the plasma therapy data originally came out with the SARS epidemic in 2013, the original coronavirus, and they found that the most effective treatment, plasma treatments were in these earlier set of patients who have mild to moderate disease, or after exposure in asymptomatic patients to prevent them from becoming symptomatic. All of the work that people are doing now, though, is on more severe disease. So it may be more effective in earlier cases. Remdesivir has gotten a lot of press lately. Anthony Fauci thinks that this is very promising. He's been leading America's sort of trial about this. And the reason it's been promising is because it's been a fairly large randomized controlled trial that found that remdesivir was better than placebo and caused a faster time to recovery. So the average patient who got remdesivir left the hospital in 11 days compared to 15 days with placebo. So I think it's very promising. Unfortunately, the difference in death rate was no different with remdesivir. So this is just one sort of tool in the arsenal, but it may not be sort of the answer, given that there's no difference in death rates in patients who got remdesivir versus those who did not. And other antiviral medications, such as lopinavir and ritonavir, have found to be no benefit from standard care. And the big thing that, there's a lot of news, I don't know if this is the case in Ethiopia or not, but hydroxychloroquine, because President Trump felt that this was the answer to a lot of our problems, really pushed this and made it a national policy for America to get hydroxychloroquine. The original data was based on a study from France, which is a very small number of patients, and they found a 100% cure rate using hydroxychloroquine. But subsequent studies with larger numbers of patients found no benefit of hydroxychloroquine over placebo or supportive care alone. And in fact, they found that hydroxychloroquine was associated with greater cardiac side effects and a worse outcome in patients, particularly if azithromycin was added, which served to potentiate the negative effects of the hydroxychloroquine. So essentially, hydroxychloroquine has fallen out of favor despite a lot of press initially about its use. Now, the long-term answer, of course, is going to be vaccine development. And typically, vaccines take years and years to develop. And it goes from preclinical trials to phase 1, phase 2, phase 3. We're hoping to really shorten that time frame for COVID-19. Even though it's taken years for other vaccines to be developed, a lot of experts feel that we may be able to have some kind of vaccine in about 18 months. In fact, in some ways, I'm even more optimistic than 18 months, only because I've seen these sort of collaborations, international collaborations with people working on it at extremely high levels. These are vaccine and virus specialists who are studying it and getting a lot of funding from the government and from private sources. So there's a hope, at least, that this process of testing and experiment and coming up with a vaccine will be much quicker. And they already have a couple viable candidates. So I know at Oxford University they've started testing, doing phase 1 testing on a vaccine for COVID. And at the end of the day, this will be the answer. Coming up with a vaccine for COVID is what's going to solve essentially all of these issues. I think it'll be more than just treatment for sick patients or trying to do social isolation. So now we'll kind of transition to the second part of this talk, which is my experience, or the United States and New York's experience with COVID and what's happened, and what kind of lessons other countries could potentially learn from what has happened here. In the United States, the first COVID cases presented in January, about a month after the cases presented in China. The first case actually presented in Washington, in the western part of the United States. And in New York, about a month or 5 weeks later, we had our first case in New York City. And it was a woman who had returned from Iran, which had already been dealing with a COVID crisis at that time. And I thought I'd create sort of timeline of what's been happening at a national level, as well as what was going on in a state and at Mount Sinai. So, around that time that we had the first case in New York, first set of cases in America, at the end of January, basically, the President of the United States felt like this was not an issue and constantly put out these statements like, there's very little problem, we have it under control, COVID is not going to be an issue. Trump, for whatever reason, including fear of the virus, did, to his credit, ban some travelers, but not all, from China when these first cases started to appear. Now, by February, and this was sort of the magic period when the virus was potentially spreading asymptomatically, but there were only a few cases still. So by the end of February, there's only 51 cases, and the government was essentially saying that everything's under control, that we have this, and within a few days, things will be gone. Essentially, COVID won't be a problem. This is by the end of February. However, by early March, it was clear that this was going to be a problem. So by March 10th, we had 1,300 cases. So it went from 50 cases 2 weeks before to 1,300 cases in the hospital in the United States. And at Sinai, we canceled all in-person group meetings. So this is when we started to use Zoom for our M&Ms and grand rounds. And we started placing a limit on hospital visitors. So, if you had if you had a family member who was sick in the hospital, only 2 visitors at a time, the cafeteria was closed. So we started to understand that this is going to be a significant problem. The president was still saying this is not going to be a problem. It'll go away on its own. This is by the middle of March, essentially, when the cases were going up. But to its credit, again, even though he was making these statements or saying that this isn't going to be a problem, all travel to Europe was suspended. And at Sinai, they put a policy of no travel for any employees. And the idea was not that employees would spread it, but that this was going to be a major issue and that everyone needed to be available to be able to take care of patients. So essentially all vacation policies, all these things were canceled. And a national emergency was declared soon afterwards. By the middle of March, all elective surgeries were canceled. So all urethroplasties, prostatectomies, nephrectomies, for cancer cases, for reconstructive cases, for stone cases, everything was canceled for elective surgeries, and public schools in the city began to close as well. So this is the middle of March now. And at Sinai, we started seeing the numbers increase. So we took these measures, but these patients had already been affected during that golden period in February and early March. And we went from 83 cases in March 19th to 390 cases just 6 days later, or 5 days later. And this is just at Mount Sinai. So every hospital in the city, including New York Presbyterian and NYU, was seeing the same kinds of numbers. In March 22nd, there was a stay-at-home order in New York. So there's still not a national stay-at-home order, but the governor of New York ordered that everyone stay at home. And over time, you essentially saw these numbers boom. So within March 24th to April 9th, we had 2,000 patients with COVID at Mount Sinai alone, and almost 450 patients who were in the ICU on a ventilator, just at Mount Sinai Hospital alone. And at this point, there was a real fear that we would run out of ventilators. We were using almost 95% of all of the ventilators that were available at the hospital. This is Sinai, the black building on the background. So Sinai partnered with another organization to build these tents, essentially, mobile hospitals out in Central Park to prevent, because there was a fear that we would run out of space and that basically patients would die because we wouldn't have enough ventilators. So the numbers are still increasing and we were seeing an exponential rise, and we were at 95% ventilator capacity. So this is when the real panic hit, and a lot of doctors were being redeployed, as I'll talk about in a second, to help cover COVID patients. And we were really concerned that we're going to have a massive rise in deaths. Fortunately, however, that was the peak. So over time, the numbers started declining, and this is probably the effects of the New York stay-at-home orders and the mask and all this personal protective equipment everyone was wearing. So I think government policy was having an effect. Even though the projections had been about 3 or 4 times the number of cases originally of what would happen in New York, we hit the peak well below those projections because of policies that the government took. And by May 11th, we were at about 1/3 or 1/4 of the number of patients in the ICU. And you can see this in the graph. This is Sinai's data. Basically, we hit a peak and the numbers started declining substantially, and they've continued to decline since then. And now we're beginning to talk about opening up elective surgeries as well. But New York served as sort of a gateway to the rest of America. There's been one study that looked at strains of the virus, and they found that the majority of strains of the virus that infected the rest of America during this period came through New York City. So, basically there was still not a national stay-at-home order, and a lot of people from New York were just leaving New York because the virus was hitting New York, and so they escaped to Michigan. They went to Wisconsin or wherever they were going back home to their families, and brought the virus with them to these different areas. And this is, again, to me, a failure of government policy. So we had a policy that protected New Yorkers who stayed in New York, but didn't protect the rest of the country. And overall, this is from about 4 or 5 days ago, I got these numbers. New York had about 200,000 COVID cases and about 20,000 deaths, or 19,000 deaths from COVID. So pretty substantial. This is New York City, and the majority of New York State's cases were from New York City. In the United States, what we've seen, though, is that the COVID is spread from New York to the rest of the country in some ways. The total number of cases are now about 1.3 million. This is from about 3 days ago, and I think the number of deaths are about 85,000 in the United States. So we're getting almost to 100,000 deaths in the United States. And even though the numbers in New York City have declined substantially because of these stay-at-home measures, in the United States, the numbers are flattening out. So a lot of, and they have not declined in the same way as it has in New York. And a lot of this is because we don't have these protective orders that the rest of, that the country doesn't have lockdown orders yet, and people are starting to open up, even though there's significant evidence that shows that that's going to cause a disease to spread. So New York is getting better. I think the country is not essentially. And this is just a graph showing all of the new cases in New York City. And you can see a pretty precipitous decline in the number of cases that have occurred after this very scary peaks that were hitting New York. What's important to know when we're thinking about this is that this disease happens very, very quickly. And so the first, as of March 10th, Trump was saying that this disease is not going to be a problem and that we'll get over it very quickly. On March 19th is when we hit our first sort of set of cases in New York City. 3 weeks later, we were at maximum capacity. So if you're a policymaker or if you're the head of a hospital trying to think about how are you going to manage this disease, you're essentially working with a very, very compressed time frame. You have very little time to make decisions that have massive impacts. So at one point, you only have 80 cases and you're saying everything's going to be okay. 3 weeks later, you have 2,000 cases, and the disease is already spreading widely, and you've lost that sort of magic time in which you could have prevented this disease from spreading widely. And it's very difficult. It's very difficult when you're at early March or late February, as I'll talk about, to make these sort of economically devastating decisions to close the country down to save the country, because no one sees the coronavirus everywhere. But what's kind of scary, though, is there was a random testing of 3,000 people in New York City, and they found that COVID basically existed in almost 20% of patients, or 21% of patients, they had antibodies to COVID in New York City. So the numbers that I've been showing here, I think, are dramatically different than the actual numbers of COVID patients and patients who've been exposed to COVID. So if you extrapolate this number, then in New York City, there's probably 2.4, 2.7 million people had COVID at one point, which is a massive number of people who had it. The numbers are lower in more rural parts of the state and go down to about 4%. But in California, for example, they looked in San Diego at the incidence of patients who had COVID, and they found 4 to 5% of patients had COVID in California. And again, if you extrapolate these numbers, that's 2 million people in California probably had COVID. So the numbers are far, far greater than anything that we've seen, and much more than what it looks like. The flip side of it is, I think the death rate is probably lower than what's been published. So everyone's been thinking that the death rate is about 1.5%, 1.4%, but it's probably much, much lower. And because of the measurement of asymptomatic carriers, has been, we've undermeasured asymptomatic carriers. Now, within the own department, I can just say, and this is something, in Ethiopia, which may happen in your department, we probably have 30 to 40 members. We've probably had about 5 or 6 members, at least say that they've had antibody positive, so they've been exposed and had COVID. A few of our members were admitted to the hospital and had to be on respiratory support briefly. Fortunately, no one has died, but one thing that is scary is that we've had nurses who had COVID as well, who then transmitted it to their family. And we've had a couple family members die because of the secondary transmission through the hospital. And this is something that when you're getting exposed to this at Black Lion Hospital, that you'll have to be really careful about how you're going to isolate yourself from your own family, because there's a chance you can expose it to elderly parents or immunocompromised family members. And these are some of the lessons I've seen. And what we did is I separated myself from my wife and the kids. My wife is a gynecologist, and she had much heavier exposure because she was working at the city, and the city had converted her hospital to a COVID hospital. And we didn't want to expose our children and expose our parents to it. And so at one point, again, we were living separately to prevent this kind of exposure. And these are the kinds of things you'll have to start thinking about as, God forbid, but if COVID really hits Ethiopia the way it's hit America. So these are some of the lessons I think I've learned or looking at. I had experience because I was in India right when COVID was first heading. Italy, we have a really good example. So if you look at Italy, India, and the United States, essentially the cases first all started at about the same time. So at the end of January is when they first started having their cases. India, and I was in India at this time giving a lecture, began screening at airports very, very early. So they were checking temperatures, taking a health history, and determining if anyone had traveled to countries such as China or Iran, where the COVID had manifested much earlier. And very, very early in the process in India, by March 22nd, at a time when they're in a country of 1.3 billion people and only 7 deaths, so there's minuscule number of deaths, the Prime Minister of India locked down the entire country and had a national stay-at-home order. In Italy, they basically did it very, very gradually, and I'll show in a second. I think that really condemned them to a much worse outcome. In the United States, we still don't have a national lockdown policy, and the number of cases are still increasing, so we haven't seen the light at the end of the tunnel yet in the United States. Italy, because of its sort of haphazard approach towards the coronavirus, had one of the highest death rates on a per capita basis of any country. And you can see here, India is basically nothing. It's not even on this schedule. So one sort of instructive example from Italy is looking at 2 different sort of regions. One is a Lombardy region and the other is a Veneto region, which is essentially where Venice is located. Lombardy is about twice the size in terms of population as Veneto, but had almost 20 times the number of deaths as Veneto. And partly it's that in Lombardy, they took a very, very different approach towards managing this disease than Veneto. In Lombardy, there were far fewer tests that were available, and they only focused on patients who presented to the hospital with symptomatic disease. So when patients would present, they would admit them to the hospital and then treat them, but they didn't look at any of their contacts that person may have had. They didn't sort of chase down people who look for asymptomatic carriers. Unlike Veneto, which basically did extensive testing throughout the region of both symptomatic and asymptomatic cases. And if anyone proved to be positive, they chased down anyone that person had been in contact with in the region and tested them as well. So that extensive contact tracing. The other thing they did is come up with a plan for home diagnosis and care. So healthcare providers would go to patients' homes and test them there. And that prevented those patients who were symptomatic from walking to the hospital, where they would potentially expose people on the way to the hospital and then exposing more people at the hospital. And they provided really good care for healthcare workers to have personal protective equipment. They made sure they had N95 masks and everything to prevent the healthcare providers from getting sick. Unlike Lombardy. So here we have almost 2 regions in the same country with very, very different outcomes based on government policy. And we can see what sort of works and what doesn't work. The other things that we learned from Italy is that partial solutions generally don't work. So one of the things that Lombardy did was, as patients got sick, they basically created what they call a red zone, where there is no travel within that red zone, but they didn't do anything about the zones outside of the red zones. And they just said, oh, because they were afraid of the political cost of this. And a lot of times the people in the red zone would sneak out and go to the other zones and start infecting the rest of Italy. So instead of having sort of a national policy or just locking down everything, they only locked down areas that were considered, quote, hot spots, spots that were problematic, rather than looking at, again, asymptomatic areas. The problem was that the facts on the ground changed very rapidly, and Italy was constantly sort of chasing after these cases, looking for hotspots, and hotspots were just exploding everywhere, rather than aggressively taking prophylactic maneuvers. And as I said earlier, people would just go from the hotspot to a cold spot because they wanted to escape COVID themselves, not realizing as asymptomatic carriers, they would be carrying the disease to other parts of the country and causing more spread. And there was no set of coherent actions that were being taken. So there still wasn't a national policy to try to coordinate, where, and in America, we don't have this either. There's no policy to coordinate who needs ventilators, who needs protective equipment. Because the president didn't have a policy, every state was left fighting for its own sort of, for itself. And every state was bidding with other states for getting ventilators and getting protective equipment. The flip side of it is India had a very aggressive national lockdown policy very early in the disease, before that many people had died. And proportionally speaking, India has done incredibly well. I mean, if you think about it, India is full of dense cities with a lot of people, like Bombay, Delhi, like in Ahmedabad and Gujarat and Madras, where people are in very, very close proximity to each other. Yet the number of deaths are minuscule compared to what has happened in America. And I think India, when they only had 7 deaths in the entire country, they locked down the entire country. And it comes at a political cost, and it comes at a social and economic cost, but it saves a lot of lives at the end of the day. So early aggressive action by the center government, I think, with a centralized policy to plan for the entire country, is, I think, really critical. I think educating the population is really critical. And we have to recognize our cognitive biases. So what ends up happening is, in February, when there's only a few cases, there's a tendency to say, oh, gee, this is likely just going to continue the way things are now. Why be that aggressive right now? So we have this sort of inertia, because things have always been this way, things will continue to be this way. But it's clear that the most effective action is the most effective time to take action is early, when the disease is very small. And the problem with doing this is that if it works, it looks like an overreaction. So if you're a politician, or if you're the president or governor, and you shut down the entire country, and there aren't that many disease cases, everyone's going to complain, saying, gee, why do we shut down the entire economy when only, there's only 5 or 6 people who died? What they don't see is what's happened in America or New York, where hundreds of thousands of people will be dead, because you didn't take this aggressive action. So politically, it's complicated, because you're taking aggressive action very early, facing the political consequences of doing that, yet you're going to get punished for it. And you've got to take aggressive, complete action, that is not just a partial solution. We know that what doesn't work is that if you don't share solutions, so there's no reason that every city, every country has to reinvent the wheel, has to compete for resources, with other cities and states. And also, I think one of the concerns is that a lot of healthcare workers were getting fired in America because they were complaining about lacking personal protective equipment. I think as people, administrators of the hospital, it's clear that we have to listen to what people are saying. If they don't have equipment, we have to be able to provide that equipment to them. And I think, collecting and disseminating data is very important. So, we have to figure out what works, what doesn't work. One of the things in Italy that made it difficult is that lab tests had different sets of accuracy. So it was unclear whether the labs and the kind of numbers we were getting were even accurate or not. And I can just say, on a sort of to finish this talk up, as urologists, it's had a pretty significant impact on all of our lives, and I think it may on your life as well. To begin with, all of our non-urgent cases were canceled. So we went from being, very, very busy doing a lot of cases to essentially doing nothing. Because we weren't doing anything, the hospital redeployed actually a significant number of the urologists to start taking care of ICU patients and start taking care of other patients in the hospital. So a lot of my colleagues were learning how to manage ventilators for the first time in their, since they were residents again. There's also significant exposure to disease, as I mentioned. We had a lot of members of the department were exposed to the disease. And I think there's almost like a post-traumatic stress disorder, and it causes a lot of anxiety and tension. I've seen this even, among close friends who are constantly exposed to this. And right when it's hit its peak, they had trucks outside the hospitals carrying dead bodies out because the hospital morgues were filled. And that kind of thing has a significant trauma, I think, on patients. And there's also personal trauma. We were separated from my wife and the kids for some time, and that extracts a toll on us as doctors not to be able to see your family, and then being exposed to the hospital, being exposed to death every day without those kind of supportive networks that existed before can take a substantial toll. On that note, I want to thank Dr. Wandawasan and everyone here. This was at a lovely time when I visited Ethiopia, and I still remember this time quite fondly. So I hope that was useful. You can follow me on Twitter, Dr. Yura Recon, or send me an email or questions if you have any. So thank you again, Dr. Wandawasan and Dr. Amare, for organizing this talk.
Thank you, Dr. Rajveer. Thank you for your excellent presentation. Actually, you presented it like an epidemiologist. We have just a few questions. One is, what are you doing with your residence training, the research in your unit or department, or research which should be done by residents? Because this is one problem. We have like 30 residents now in the unit, and most of the teaching hospitals are almost closed now, and we don't know where to put them, and they are complaining actually.
So,
also the research is part of their training, so they have to write, they have to do the research on a topic, and that is also affected. What are you doing with that?
So I think there's a few things. One is all basic science lab research was put on hold at Mount Sinai, and it's actually starting again next week on the 19th. This is actually kind of a good time to do clinical research, though, because you can still get charts from patients. You can still, and because you have a lot of free time, which you don't have when you're a resident running around, taking care of patients and doing surgeries, this is the time to do clinical research and look at outcomes, look at charts and see how patients have done, or make phone calls and follow up on patients. So to me, in some ways, this is sort of a golden chance. And we've actually been, as a department, quite productive and written a lot of papers during this time when we were underemployed. The other thing that's happened is a lot of our residents were actually redeployed as well to cover the hospital. And this is particularly at the peak when we almost had 2,000 patients. So the residents were redeployed to work in the ICU. They were redeployed to work, essentially almost anything that was needed, they were getting put back to work. They weren't doing surgeries, but I think they were proving useful. And then finally, what we did is, and I would encourage all the residents to look at this, is we have a series of lectures, like Zoom lectures that were organized that if you have free time, it's a great time to go through. So in New York, for example, if you look up the Empire, EMPIRE lecture series, it was organized by one of my colleagues, Dr. Alex Small, and by some of his colleagues at Columbia. And so it's basically, because the faculty have free time as well, we all gave lectures, an hour-long lectures that are available online now to watch. And then this has been replicated at a few other centers in America, but they cover the whole range of topics. So I think it's a great chance to do some learning and to go through these lecture series, if you're not operating.
Okay, thank you. You see, for us, today they have reported 9 cases, and the total number of cases in the country is now at 272.
Yeah.
We don't know why we are having this it's almost 2 months now, and this is the total number of cases in the country. We epidemiologists were trying to see what's happening. They checked the mortality rate in the country, and actually it has decreased for March and April.
Oh, that's great.
Yeah. So we thought because we are not doing a lot of testing, we are missing some of the cases, but it doesn't seem that. Again, they are checking every patient with pneumonia. They have tried to check some of the high-risk workers like doctors, pharmacists, and what. What do you say about the effect of altitude on the number of cases? I don't know if you have seen this article where they mentioned altitude will affect the ACE2 receptor, and people living in high altitude area might not be affected as those who live in a lower altitude area. Do you have any information on this?
No, I haven't seen the article, but it's clear that there's a lot we don't know about the disease. So one reason India may have also done very well, like Ethiopia, is just temperature. The studies where we talk about contact, spread, for example, were done in a different environment with a colder temperature in a lab setting. And it might be that the virus just doesn't stay very long in hot temperatures. I assume it's the hot season right now in Ethiopia.
Yes.
Is that right?
Yes.
Yeah, Dr. Wanda.
Yeah.
So it's the same thing in India right now. It's sort of the hot season is happening. And so partly maybe things that all these variables that we don't know yet. Maybe it's the BCG. I don't know. Do you receive the BCG vaccine at all or no?
Yes. Everybody gets it.
Yeah, so it may be the BCG vaccine. It may be, who knows? I think we should count our blessings and recognize that the disease can change. But there's a lot we still don't know about this.
Okay. When do you think things will be near normal, and we start our routine cases, and hopefully your visit to our unit we were waiting for?
I would love to come back.
Yes.
What we're doing at Sinai is coming up. I don't think anything will be normal in the next few months, like normal per se, and going back to the way things were 3 months ago or 4 months ago. But what they're doing is coming up with a strategy where patients get checked for the disease the day before any kind of surgery. So they're getting testing done, and the testing is much more rapid, so we don't have to wait 5 days like we used to wait. So prior to surgery, they get tested to see if they have the COVID, and if they don't, we can proceed with the surgery. We're creating sort of different units for COVID patients compared to regular patients. We're still we haven't yet started doing elective surgeries yet, but we're starting to sort of get to that point where the cases are small enough where we're trying to figure out how to do it safely. There have been some reports, for example, particularly early in the process, of patients who had elective surgeries at the hospital who developed COVID and died. And that would be the worst situation, where someone who otherwise would have survived develops COVID from being at the hospital. I mean, who knows? I don't think anything will be normal for many, many months. It may take even years for things to get back to a normal state. But hopefully in the next few weeks, we'll come up with at least a strategy to keep patients safe, and it will probably involve testing significantly for COVID.
Okay. I will invite probably Dr. Bada if he has any question. Dr. Bada, can you hear me?
No, I think you.
No, okay, fine. Just one more question. The number of antibody positive cases you have now is so huge. Do you think that is just from this episode, or is there any some cross positivity with any other virus, similar virus, or
I think that's I think that's a great question. And so that's been one of the concerns, is that the antibody test really hasn't been validated, and we don't know how accurate the test is. And so there may be cross-reactivity with other viruses, but it's getting better. And I think there are some tests that are more accurate than other tests. And I think the numbers are huge, actually. I really do think, because there's been another study that came out in Spain that found that the number of patients who had antibodies was 10 times the number that had been reported of infections. And so I think this exposure is much more massive. I think that the COVID spreads much more easily than we think it does, but I think it's also probably less deadly than we think it is. So I think much fewer people on a percentage basis are dying. Unfortunately, I mean, I think the hope has been that enough people get the antibody that we develop herd immunity. But I think that the herd immunity really requires like more than 50% of the population to have the disease. And we're not quite there yet, at 5%, 10%, 20% of the population. So we still have to have a lot more people to get infected for that to happen.
Yeah, but if this is true, I mean, it is a good news in a way. 10 times the number of cases you have. So pretty soon, in a few months' time, you might reach 60%, or then you might have herd immunity. Then everything will be probably back to not normal, but near normal. Anyways, I don't know if this is also happening in Ethiopia. We have to start the antibody testing, but I hope, I don't know, the infection is spreading probably, and we are not picking it, and people are developing immunity. We don't know. Anyways, they are planning to start antibody testing. Probably we will know in a few weeks. The other thing about hydroxychloroquine, chloroquine, we use it. I mean, in India, use
malaria primarily.
Is used for malaria.
Yeah.
And we don't have that side effect, cardiac side effects, and what. And initially, it was included in the national guideline for treatment of COVID patients.
Yeah.
So we didn't have that many cases, anyways. So probably that may be different from what you are having. And
well, the population's a little different also. I mean, these are ICU patients who are intubated and on a lot of medicine. So I think the effect may be different because of the patient population being different than just a general population that might, do I take it for malaria prophylaxis or as treatment?
Exactly. Yeah. Your patients are with comorbidities who are in ICU, and I think you are testing it on these cases. Anyways, so I hope we will continue our communication, and as soon as this thing is handled, we hope you will come and visit our unit, probably with your colleague.
I would love to come.
Yeah, we want to start also probably to do a few cases of laparoscopic procedures. So I will continue to do that. Another thing, we might also plan the posterior retinal disruption thing. We can think of it now because we have the time to develop the protocol and start the study.
I would love to be involved in that. So
okay, thank you.
Okay. Thank you so much, Dr. Wandas, and thank you, everyone. So stay safe.
Thank you very much. Okay. Have a good day.
Okay, bye-bye.